only licensed clinicians can sign MD orders. That's it. Like nobody else. So make sure that only licensed clinicians are reporting to doctors or receiving orders back to doctors and things like back from doctors and things like that. This is very, very important. Hi everyone, my name is Mariam Treystman from the Home Health Consultant, and today we're going to be talking about MD orders. But first, if you like our content, please like, share, and subscribe. So what is an MD order? Well, if you're brand new to home health, this could be a little bit confusing, but pretty much an MD order is a directive from the doctor who is supervising or directing the care about what it is that we're doing. So whether it's a care plan, like just a basic order or, whatever, it pretty much describes some kind of like patient situation and what we need to do with that patient. So one interesting thing about MD orders is that while this is an order from the doctor, most MD orders that happen within a home health or hospice agency are generated in the home health and hospice agency. But we're kind of getting a little ahead of ourselves, so let's kind of backtrack and talk about where do MD orders start? How does this work? So the first MD order you're going to get is a referral. The referral pretty much allows you to initiate the care. The referral is an order from the doctor saying, please, evaluate or treat or whatever this patient for these reasons. Sometimes a referral has very little information on it. I've seen referrals that are just like a little prescription pad and it says the patient name and it says eval for HH services or, something like that. So sometimes you get absolutely no information, then you have to go asking for more info and things like that. But essentially, it is a directive from a physician or an NP or, whoever has the authority to give this directive in home health and hospice about what it is that we need to do for a specific patient. So after the referral, let's say you admit the patient based on this referral, this and that. The next kind of MD order we're thinking about and working on is when you're at the admission. It's kind of called an admission order, I guess. So pretty much when you're at the admission, the admitting clinician is going to evaluate the patient, and then based on this evaluation, they're going to report to the doctor. This report is documented in the admission MD order. So the admission MD order is typically going to be a description of the patient condition, a list of the medications found at the patient's home, and any other identifying information about the patient that will help the doctor get a clear picture of what the patient needs. From there, based on this, call or however it is that people are reporting to the doctor, typically it's going to be a phone call. The doctor will say, okay, great, continue treatment on this kind of frequency or, something like that. Like pretty much the doctor is going to give more directions for what needs to be done. Depending on the doctor, you might get a very detailed, verbose instruction, or you might get something like send SN twice a week for whatever period of time for medication management or, it's just some quick thing. So it's going to depend on doctor to doctor or pretty much, NP or whoever it is that you're dealing with. About the format and how much information you ultimately end up getting. So another type of kind of order, but this is a little bit of a gray area, is a face-to-face document. So the face-to-face document isn't really an order in that it doesn't tell you to do something. It's just a description of the patient, but it is still something that comes from the doctor that you need, that's signed by the doctor and filled out specifically for your patient for that care. So let's move on from face-to-face, but that's just kind of a little caveat, and it happens right at that beginning period of treatment. So that's why I wanted to mention it. But it technically, face-to-face documents will not have what to do next. So the next kind of order or type of order you're going to have is a care plan. So a care plan is a longer MD order. It's like an extended document. In home health, there's a specific form we need to use. It's called Form 485 and also 487 if you're going to have multiple pages. But pretty much, and in hospice, there's no specified format for the care plan. So any any kind of like form that's going to capture the required information will work. But for home health, it's specifically Form 485/487. So a care plan is going to include a few elements. It's going to describe the patient condition. It's going to have some kind of listing of meds, either in home health, it's within the form. In hospice, it could be in the form or just kind of like see addendum. And then there's a med list in the med list area. And essentially, it's going to give you a big, long treatment plan. So whereas in a smaller MD order, the ones that we kind of go back and forth on, like if we're adjusting frequency and stuff like that, there's a lot less verbiage. But in the care plan, it's long. We're really in depth describing the patient condition. We're writing out every single medication that's on there, whatever it is. Like we're giving like detailed orders, and also we're prescribing goals. So at the end of this care treatment, these are the goals that need to be achieved. So essentially, in care planning, and this is not, I'm not a clinician, first of all, so you don't have to listen to me about anything. But in a care plan, it's essentially like in the description of the patient, we have identified problems, right? And so whatever identified problems there are typically will have associated goals. So if you're not going to work on an identified problem, there needs to be a reason why, or, something. You can't identify a health concern in a specifically home health patient and not address it in your care. But anyways, any identified issue is going to have a subsequent goal, and that goal needs an order of how to get to the goal. So that's pretty much the format of the care plan, more or less. Of course, some care plans can be like 8 pages or so much, and then this is going to depend on agency by agency if you're going to like really have a lot of information in there, versus some agencies like to keep it short, concise, quick, to the point. There's no right or wrong here. The only consideration here is that your care plan is going to be one of those like critical documents that will make or break you in an ADR situation. So you want to really make sure that even if you're keeping it clean, like short, concise, to the point, that you still get the elements that are going to justify your care in an ADR situation. The next type of order is, we just call it an MD order pretty much, but what this is, it's like the orders that are in between the care plan and a discharge, or a care plan and a recert, that are updates to the care. So pretty much once you have a care plan established, any changes to that care plan are going to need an MD order approving the changes or directing those changes. So some examples are frequency changes, missed visits, like any of those frequency bucket things. In the care plan, you're going to set out specific frequencies. Like it could be like, this is the nursing frequency, this is the home health aide frequency. Some disciplines in the care plan get addressed like this. For example, physical therapy, eval, and treatment. And then now the physical therapist goes and conducts like their own evaluation, and their care plan is going to have their frequency. So you might have a couple of care plans happening, but the main care plan is that main admission agency care plan. And from there could be a per discipline, like, little tiny care plans associated with that are kind of like little addendums to that care plan. And so any frequency related, like miss visit, the patient requests like a hold for a week, they have family visiting, they don't want care, like, whatever, like, the patient feels like 3 times a week is too much, they can't keep up with it, can we do twice a week? I don't know, just like whatever changes in frequency, things like that. Then you have changes in condition. If it's not significant changes in condition, just like maybe the patient's improving slowly, or there's like some need to increase visits or decrease visits for whatever reason, those can be handled by MD orders. Any kind of medication changes. So anything that changes in the medication list from the original care plan that you're working on. And we're doing care planning every episode. So essentially, when I say original care plan, I mean for that episode, not like like if you have multiple episodes, I'm not talking about like the first one, in a series of 12, for example. So it's just like the care plan of the episode. If there are any medication changes from that time, from that care planning, the current episode's care plan, then that requires an MD order. Same as any kind of like medication clarifications and things like that. Other kind of things that you can do MD orders include if the patient refuses care and now you can't get in there for a DC visit, just like things like that. Just anything that's different than what was planned initially in that care planning process at the beginning of the episode needs an MD order. Because what is really happening here is that care plan is what is the doctor's order to you. Like maybe it's long, maybe it's a whole thing, and maybe it's generated in the home health agency, right? Like or the hospice agency, like ultimately in the home health and hospice, we are writing these care plans. Like the doctor's not writing us a 5-page treatment summary. We're writing it based on, the doctor's orders that they have given us verbally or, however they've been given. And so then the doctor signs it. So any changes to that document or to the goals, the orders, any changes to that ultimately update through an MD order. Another kind of MD order is the discharge summary. So the discharge summary is like a summary of the patient's condition at the end of the treatment. Why are we discharging and things like that? Like how are we transferring the patient back into the community? Or in the case of hospice, maybe it's a death note or, something like that. These DC summaries need to be sent within 5 days of discharge. That's a conditional deficiency if it's not. And so it deserves its own kind of special call out, because typically the rules around MD orders go like this. There's an MD order. Whoever is reporting to the physician and getting that information back needs to write it down immediately, like immediately written down whatever the doctor says. It's not like you have a conversation with the doctor and then 2 weeks later, I'm going to write this MD order. No, it's like as they're talking, you write it and then you have to read back to them and they confirm that you got it right. It's the same thing when clinicians are going to report to the MD after some kind of visit, especially evaluation visit. They are reading that doctor. For example, there might be like 24 meds in this patient's home. They're reading that doctor every single medication, the exact like dosage, route, like the proper way to write a medication kind of. So dosage, route, frequency, the whole name of the med. So they're doing that times 24, times how many ever meds there are. And so at the end of this, the doctor needs to read back and verify those 24 meds, because one of the like biggest kind of issues that you can have is that the doctor gives you an order or you report something to the doctor and like for this reason or that reason, maybe some people are talking in the background, you're not really focusing or something's happening or whatever, and they just like miss a critical part of it, right? So that's why we have to read back and verify everything that happens. And so pretty much the minute that order kind of transaction occurs, where we're reporting, we're reading back and verifying, we're receiving verbal orders, let's say from the doctor, that needs to be transcribed immediately. And then signed and dated and timed. So I need to sign the thing. I need to write the date that I received the verbal order and the time I received the verbal order. And then separately, I'm putting the date when I signed it. So you kind of have to do this at the same time. You can't, how can you receive an order and then like transcribe it later? Yeah, some things some things you might remember, but some things you might not. So you really have to transcribe them at the time of receiving that order. Then, from the date of the order, not the date of the signature of the order, right? So like, if for whatever reason, like, should not be, but like, let's say it is, you've received the order verbally at one day and then you write it a different day, don't do that. But like, let's say the date that we start counting when that order needs to be signed by the doctor and returned to the chart is the date and time of the verbal receipt of the order, not whenever you decide to get to it and write it down. So that's why, first of all, always make sure you're just transcribing it on the spot. Have some MD order like documents, copies pretty much with you anytime if you're a clinician, just so you can like document it real quick. Because from the moment you receive that order, you now have 30 days to send it to the doctor and have them send it back to you signed and put it in your chart. If it's signed, but it's still at the doctor's office at 30 days, you are not compliant. If it's in your chart, but not signed by the doctor, you are not compliant. So you need these things back in 30 days. For the most part, this is not super difficult as long as you are documenting and transcribing as receive the order and then sending it immediately. And so if you have an internal process of like regular sending orders and receiving orders, you can probably more or less keep this within regular timeframes. The challenge that people have is it's hard to get things back from doctors, get them signed from doctors sometimes because they're just like busy. Depending on how organized their office is and what their processes are, it might just sit on a shelf for a long time at the doctor's office. And so your kind of like pro tip here, your real strategy here is just to like try to like get the work done as soon as possible and send it out right away for signature so that the bulk of those 30 days that you have is spent on returning it from their office and not sending it to them. Because we can't really control what like others do in their workplaces and offices. We could just control what we do in ours. If we're sending them fast, then hopefully we're getting them back within 30 days. But if you're sending them at day 20, I don't think you're going to get it at day 30 back in your office, especially depending on how you're sending back and forth, right? Like technically you're not supposed to be like emailing patient confidential information. And this is like the essence of it's like this person identified by name and this and that. Here's all their meds. Here's all their diagnosis. It's like a literal, like everything you don't want out in the public about your health kind of thing in a piece of paper. So you probably shouldn't be emailing these things unless you have a HIPAA compliant email and, a whole process behind that. If you're mailing, now you're just add mentally like 10 days, right? Like from your 30 days, just subtract 10 just for the mail process. And then you have to always confirm if they've received your things because, okay, like maybe the mail is not like unreliable, but 1 out of 100 letters could get lost, right? And if that 1 out of 100 is your manila envelope with like 50 orders, that sucks. So confirm receipt immediately. Then there's fax. You could fax it. This is a fast way, but like people are kind of like moving away from faxing or using emails to receive faxes. So now we're back into like HIPAA compliance and stuff like that. Still make sure you have a HIPAA secure email and like see if the fax will have HIPAA secure fax. There are plenty of HIPAA secure tech out there. So it's not impossible. It's not even hard. If you just look for it, you can find it. But just make sure you're using it because those HIPAA fines, 10K per instance, they add up quick. Or you can hand deliver. This is a little more of a costly kind of way, but usually when you're hand delivering, like what a lot of agencies will do is they'll have like someone go and just like sit there until it's signed. Okay, it's not efficient. But if you're having a hard time getting these orders back within 30 days, it's better to put that kind of investment than to be non-compliant with orders like that, because the order is the backbone of all your treatment. Like, you are legally not allowed to be in there without the order. And the order is not legitimate unless it's signed. And they allow you the 30 days to get the signed. But on day 31, now anything you've done in those 30 days is no longer like, it's not okay. It's like not okay. So you need to get those things signed back. Yeah, if you get it on day 31, 32, 33, like whatever, right? Like, and it's signed earlier, this and that, like, I'm not saying like if on day 31 you don't have it signed back that care is like non-legitimate. I'm just saying like without the order, you can't touch a patient or see a patient or do anything without the order. So who can sign an MD order? Pretty much the attending physician signs the MD order, or the NP, or, you know, whoever's like authorized to treat care at the time. Like, we're in 2025. This has recently changed. Now you can have NPs refer and sign orders and things like that. So if you're watching this like 5 years later and they've added more people, they can like be an attending physician or whatever, then just go by the laws of the day kind of thing. But the point is, whoever is directing care needs to be the one signing all the orders. So if I'm in a physician group and my doctor is Dr. A, like Dr. B can't sign for Dr. A. Dr. A needs to be the one controlling the treatment, things like that. From our end, from the agency's end, home health or hospice, right? We also need to sign the order. So usually our signature is first, unless it's a referral or something that's initiated from the doctor's office. If it's something generated in our office, our signature is first, because we are also signing for the kind of an authenticity of the information and things like that. The person who signs MD orders from your agency or on behalf of your agency or whatever needs to be a licensed clinician. A normal clerical kind of like employee of your office cannot sign any kind of MD orders. Like, only licensed clinicians can sign MD orders. That's it. Like, nobody else. So make sure that only licensed clinicians are reporting to doctors, are receiving orders back to doctors and things like back from doctors and things like that. This is very, very important. A couple of pro tips that we've kind of seen around. In your care plan, you really want to spend, even if you're going to be concise about your care plan, just want it short and quick to the point. Dedicate a section where you describe the patient in a way that's not already like, that's not like a clinical description of their disease process. You know what I mean? So typically, like with home health, we're putting this in the item 99 section. For example, patient is a 68-year-old female living alone at home. Daughter is involved in care. However, she lives in a different city, so she only calls it, you know, whatever. These kinds of like, almost like non-clinical factors. Sometimes these are things that are captured on the OASIS, but there's just like no space for them in the care planning form. Same thing with hospice. If you can just like have a quick little description of just the general overall patient like situation, it's not bad, you know? And it'll essentially just save you in the ADR process, because that's what's showing your individualized plan of care and things like that. Another thing is, make sure that all of your orders in the process of reporting, you always have a read back and verify, whether that's like meds or whatever. Read back and verify on every one of these. This is just going to save you so many times. Don't just write it. You can't write stuff you didn't do. You have to actually read back and verify, and then you can write it. And then another kind of little pro tip is, on any MD order where you're just like making an update to the care plan, like I'll give you an example. Let's say you have a missed visit that week, right? So you don't just go, just a quick example, this is not the right way to write this anyways, but you don't just go, miss visit this week, you know, start new frequent, whatever, blah, 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 blah. Describe why we have a missed visit. Patient called and canceled the visit. We tried to we tried to reschedule it. They said they don't want anything else for the rest of the week. We tried this, we tried that. They said no. that verbiage on top that's describing the actions you took to try to avoid this missed visit or whatever it is that you're doing is ultimately going to help you in ADRs. And so you really want to have, like, with ADR situations, they only see what you're giving them, right? So if you just have, like, let's say you have a chart and there's like 10 missed visits in the chart, which is crazy. At that point, it's a non-compliance case and you should probably discharge. But anyways, let's say you have 10 missed visits in the chart A and 10 missed visits in chart B. Okay, an ADR reviewer who's looking at chart A and just sees like, miss visit, here's the new frequency effective this date. Miss visit, here's the and nothing else about like why this is happening. I don't know if this ADR passes anything, you know. But the one where you're like, we tried, they said no. Then we tried again. We warned the patient, hey, you're bordering on non-compliance. You could be discharged based on non-compliance to the care plan, whatever. Or like, maybe every other week there's a random patient caregiver coming in that can but they come in randomly, but they are able and willing to carry out this treatment and do it. Like, whatever it is, just like describe the situation with the update, because that's just going to save you in ADRs. And also it's going to save you in just like situations where, let's say you're reviewing this chart like a year later or 2 years later, and like that clinician who worked on the case isn't working with you anymore. Now you're going to look at this chart and go, wow, how do we have like 78 missed visits? Like, why? And there's no way to like performance improve around that. There's like just nothing you can do if you have no explanation, So you just really want to like beef these things up with as much detail as possible. It'll help you with your performance improvement process. It'll help you with any kind of surveying that can happen, and it'll help you with any kind of ADRing that can happen. So that's like more or less the details around MD orders. Of course, all of these topics that we talk about in these videos, like these like 10-15 minute videos, we can write like 15 books on them if we wanted to go into every micro nuance. So this is in no way like a just 100% complete cover, but we are also trying to, show topics around these things in a way that a new person to the industry can start to conceptualize what these things are. Because unless you're a clinician who's worked here for, like, people aren't ready for the micro nuance until they get the big concepts going, right? So that's what we're here trying to do. We're trying to give people the big concepts before we start diving into these like extremely nuanced situations and examples. So that's it for MD orders. Thank you so much for listening and for watching our videos. And again, I'm Mariam Treystman from the Home Health Consultant. And if you like our content, please like, share, and subscribe. Thank you.